And our next talk is from Dr. Abdullah Jalal, talking about cancer and acute kidney injury. Abdullah is one of our recent recruits who has had extra training in onconephrology and is part of our burgeoning and very well-established onconephrology group. So looking forward to your talk, Abdullah.
All right. Hello, everyone. My name's Abdullah Jalal, like Dr. Mount mentioned. So it's my pleasure to participate in this board review course. I'm sorry that you guys can get a break beforehand, but we'll try to stay within our 45 minutes and hopefully a few minutes early. So like Dr. Mount mentioned, I am a nephrologist at Brigham and Women's Hospital, specializing in onconephrology. This is my brief biography. I have no relevant disclosures. And so these are our objectives for today. So one thing that I want to highlight is we won't be able to cover every cause of AKI in cancer patients, but we will focus on specific high-yield patient populations during this 45-minute talk. All right. So why is AKI in cancer patients a separate topic? Well, the rates of AKI in cancer patients are higher than in non-cancer patients, with a 1-year risk being approximately 18% and a 5-year risk of around 27%. Additionally, cancer patients with AKI have increased mortality and inferior outcomes overall, and that increases with the severity of the AKI. Not only is AKI associated with worse malignancy outcomes in newly diagnosed hematologic malignancies, in terms of the chemotherapy itself, about 15% of patients in a study suggested that these patients are also receiving suboptimal chemotherapy doses, which may be resulting in lower complete response rates. And then finally, and most importantly, with renal impairment, often our patients with chronic kidney disease and AKI are being excluded from large prospective studies, clinical trials, which are limiting therapeutic options for our cancer patients. Now, there are a couple of concepts I wanted to highlight with this diagram. So with acute kidney injury and cancer, you can have our standard causes of acute injury, for instance, hemodynamic. You can have treatment-related causes, whether it's related to the chemotherapy, immunotherapy, targeted therapies, or whether it's related to the cancer in and of itself, for instance, infiltration or obstruction. Now, all of this is modulated by cancer-specific factors. For instance, if the patient had a nephrectomy in the past, or factors such as if the patient had CKD or diabetes or hypertension, or were on medications like NSAIDs, ibuprofen, Motrin, Aleve, Advil, etc. Now, the diagram on the left just highlights that our newer anti-neoplastic agents can affect any part of the nephron, all the way from the glomerulus to the collecting duct, while the image on the right shows that these anti-neoplastic agents can also cause various electrolyte derangements. All right, so now to start off with the case, we have a 65-year-old female with metastatic lung adenocarcinoma who presents for cycle 3 overtreatment with a combination of pemetrexed, carboplatin, and pembrolizumab. She's found to have a new AKI with the serum creatinine of 3.6 milligrams per deciliter, up from a baseline of 0.8. She has a history of hypertension and gout. Medications include losartan and omeprazole. Her labs are notable for anemia, some thrombocytopenia, the AKI with a creatinine of 3.6, an elevated CRP, mild proteinuria, and an elevated urine retinol binding to creatinine ratio. On imaging, the patient has no hydronephrosis. So which of the following is the most likely cause of the patient's acute kidney injury? Is it post-immune glomerulonephritis from the pembrolizumab? Is it acute interstitial nephritis from pembrolizumab? Is it acute tubular injury from the pemetrexed, acute tubular injury from carboplatin, or is all of the above possible? So I'll give a couple of seconds for the audience response questions. All right. So the answer in this situation is E, all of the above. So we'll start off by talking about conventional chemotherapy, starting with the platinum agents. So the platinum agents include cisplatin, carboplatin, and oxaliplatin. Now, the incidence of AKI with cisplatin in particular is approximately 30%, with lower incidences with carboplatin and oxaliplatin, which are later generation platinum agents. In terms of renal manifestations, it's primarily early direct tubular toxicity, often within the first week. And these patients can often develop tubulopathies, electrolyte derangements such as partial or complete Fanconi's, hypokalemia, hypomagnesemia is quite common in these patients, in addition to hyponatremia, and rarely thrombotic microangiopathy. In terms of risk factors, elderly age greater than 60 is considered to be a risk factor. And also the dose of the medication plays a very significant role. So a high single dose or large cumulative doses play a significant risk factor. In terms of the mechanism of injury, cisplatin enters the proximal convoluted tubule via transporters, and so it accumulates within these cells, and when it accumulates, it activates apoptotic pathways, causing oxidative stress, reactive oxygen species generation, and inflammation. Now, in terms of can we predict which patients develop an AKI associated with cisplatin? And so two of my colleagues, David Leaf and Shruti Gupta, published a paper in the BMJ in 2024, which looked at cisplatin-associated AKI, and they developed a risk calculator, which can be found on MDCalc, highlighted on the right. And you can use this risk calculator to determine whether a patient is high or low risk for cisplatin AKI. Now, in terms of prevention strategies, many have been proposed: volume expansion with saline, aminophosphine, celastin, forced diuresis with mannitol. All of those have been trialed with limited efficacy. More recently, SGLT2 inhibitors and magnesium have shown more promise, and I'll be highlighting one study. So this again is by my colleague Shruti Gupta, published in JAMA in 2025. And this looked at giving prophylactic IV magnesium prior to cisplatin therapy. And this study found that giving IV magnesium on the day of cisplatin therapy reduced the incidence of cisplatin-associated AKI from 5.3% to 2%. The proposed mechanism behind this is that magnesium deficiency results in downregulation of efflux transporters, resulting in more cisplatin accumulation. And so by repleting magnesium, you restore expression of these transporters and limit intracellular cisplatin accumulation. Now, in terms of treatment, typically this involves holding the platinum agent with usually reversible effects with the AKI. Some of the electrolyte derangements, like cisplatin-associated hypomagnesemia, can last many months to potentially even years. I'd also like to highlight that there is a limited role for cisplatin clearance via dialysis because it is highly protein-bound after 24 hours. And then I've listed some GFR thresholds that are commonly used for these platinum agents. For cisplatin, it's typically higher eGFRs greater than 45, whereas oxaliplatin can be used with much lower eGFRs. All right, moving on to another very commonly used conventional chemotherapy, methotrexate. So the incidence associated of AKI with methotrexate toxicity is approximately 10%. It's primarily used in CNS lymphoma and leukemia due to its very high CNS penetration, and it's also used in osteosarcomas. It is an antimetabolite, so it inhibits dihydrofolate reductase, and it is active against rapidly dividing cells. In terms of elimination, approximately 80 to 90% of it is excreted renally in the first 24 hours. Risk factors associated with methotrexate nephrotoxicity include high dosing, low urine pH, volume depletion. Additionally, prolonged clearance, such as third space fluids, including ascites or pleural effusion, can be reservoirs of methotrexate, and so that can result in prolonged clearance, chronic kidney disease, drug-drug interactions. In addition to patient-specific factors, as previously mentioned, older age, diabetes, chronic kidney disease, and genetic mutations that prolong methotrexate clearance. Now, in terms of renal manifestations, it's primarily acute tubular injury from renal vasoconstriction, but also low urine flows and low urine pH result in methotrexate crystallizing and forming intratubular crystals and obstruction. Extrarenal manifestations, again, because it acts against rapidly dividing cells, include myelosuppression, mucositis, dermatitis, and hepatitis. Now, in terms of management of methotrexate nephrotoxicity, generally the prevention strategy is urinary alkalinization with oral and IV sodium bicarbonate with serial monitoring of urine pH, aiming for a urine pH greater than 7, usually between 7 to 7.5. We also want to maintain high urinary flow rates greater than 2.5 liters. And with methotrexate, typically we give leucovorin, which is a folic acid derivative, which allows for restoration of purine and pyrimidine synthesis. One thing to keep in mind is with high methotrexate levels, you have less efficacy of leucovorin, at which point we may consider an antidote called glucarpidase, which we will discuss later. And then hemodialysis is less effective with methotrexate toxicity because methotrexate is low molecular weight with moderate protein binding. So it's not ideal for extracorporeal removal, and it often requires multiple hemodialysis sessions. And post-dialysis levels commonly rebound once dialysis is discontinued. Now, in terms of glucarpidase, it is a recombinant bacterial enzyme that cleaves methotrexate to glutamic acid and an inactive metabolite called DAMPA. It rapidly reduces plasma levels by greater than 95% within 15 minutes. One key thing to keep in mind that it does not penetrate cell membranes, so it can't reverse any intratubular toxicity. The use of glucarpidase is heterogeneous across clinical centers, with each center typically having its own site-specific protocol and parameters for glucarpidase use. And one thing to keep in mind is with glucarpidase, post-use, the inactive metabolite DAMPA is picked up on the methotrexate assay for up to 48 hours afterwards. And so oftentimes you have to use high-performance liquid chromatography or mass spectrometry to measure methotrexate levels. Otherwise, they may be falsely elevated. Now, there has been talk about the use of prophylactic glucarpidase, especially in patients that will receive multiple cycles of high-dose methotrexate or patients with solitary kidneys or chronic kidney disease. And the reason for this suggestion is a study by Gupta et al. Published in Blood showed that there is faster time to recovery with the use of glucarpidase and the lower risk of extrarenal manifestations such as neutropenia and transaminitis, which can also delay further cycles of methotrexate. Now, the one barrier to the use of glucarpidase is its very high cost, and also frequent use can lead to antibody formation, which results in higher and higher doses of methotrexate being needed. And this is the aforementioned study published in Blood by Gupta et al. In 2025. All right. Now, moving on to our second case, we have a 70-year-old female with metastatic pancreatic cancer, initially treated with FOLFIRINOX, and she was later switched to gemcitabine and Abraxane after she developed disease progression. She then presents for cycle 8 of her treatment, and she was found to have a new AKI with a serum creatinine of 2.4 milligrams per deciliter from a baseline of 0.9 milligrams per deciliter. She has a history of breast cancer as well, which is in remission, medications as listed below. In terms of her vitals, she does have uncontrolled hypertension with a blood pressure of 180/110, and her labs are notable for anemia, thrombocytopenia. She does have the elevated creatinine of 2.4. She has a normal C3 level, but she has a low C4 level. And then her LDH is high, her haptoglobin is low. She doesn't have schistocytes seen on her peripheral smear. On her urinalysis, she has many red blood cells seen, no white blood cells, and she has an elevated urine protein to creatinine ratio. And on her imaging, her renal ultrasound is unremarkable. So the patient did get a biopsy and she was diagnosed with a thrombotic microangiopathy. Which of the following are risk factors associated with thrombotic microangiopathy in the prior case? Is it uncontrolled hypertension? Is it the presence of schistocytes? Is it low C4 levels? Is it high LDH and low haptoglobin, use of gemcitabine, or all of the above? I'll give you a couple of moments to respond. All right. And the answer is F, all of the above. Now, Gemcitabine is an antimetabolite, and it's typically used in GU cancers such as ovarian cancer, and it's also used in pancreatic and other solid tumors. Now, the incidence is anywhere from 0.3 to 2.2%. Oftentimes, gemcitabine related AKI is underdiagnosed because many cases often present as a renal limited thrombotic microangiopathy. And the case on the right illustrates this. This was a study done in France by Maisons et al., which found that patients with thrombotic microangiopathy and native kidney biopsies, about 45% of those patients presented exclusively with a renal limited thrombotic microangiopathy and no complement abnormalities. In terms of risk factors, the duration of exposure is a major risk factor, as well as cumulative dosing. Now, in terms of renal manifestations, there's an insidious or delayed onset with a median time of approximately 156 days. Features of systemic thrombotic microangiopathy include thrombocytopenia, schistocytes, AKI, and proteinuria. But one thing that can be an early signal and should be closely monitored is new onset hypertension or worsening of previously well-controlled hypertension. In terms of the pathophysiology, it is an unknown mechanism that's not fully elucidated, but it's been proposed that it's direct endothelial damage, exposing the subendothelial extracellular matrix, which results in complement activation. And this is supported by C5b9 deposits in the kidney. In terms of treatment, it's stopping the gemcitabine and supportive care. The data behind Plex with gemcitabine has shown limited efficacy, and there's increasing data suggesting the use of eculizumab with gemcitabine-mediated AKI. All right, moving on to immunotherapy. So immune checkpoint inhibitors block immune checkpoints and release the brakes on the immune system. So this results in nonspecific T cell activation. And so these T cells, while they preferentially act at the site of the cancer, they can travel to any organ system, resulting in inflammation and damage. So the diagram on the left suggests some of those immune-related adverse events, whether it's hypophysitis, adrenalitis, colitis, rash. And so the incidence of these immune-related adverse events is anywhere from 60 to 80%. One point I want to make is that there has been a positive association between low-grade immune-related adverse events and clinical response and survival outcomes in patients with cancer. This could be because the presence of an immune-related adverse event is representative of a robust immune reaction. Now, in terms of a time course, they can occur at any point in the patient's treatment course, although most commonly within the first 3 months of treatment. The graph on the right shows the kinetics of different immune checkpoint inhibitors. The most common immune-related adverse events are dermatologic, such as skin lesions, rashes, pruritus, and GI lesions, primarily colitis. Now, like I mentioned, any organ can be affected, and that includes the kidneys. However, it's important to note that cancer patients are often very sick with multiple comorbidities and can have many reasons for AKI. Therefore, not all patients that are receiving AKIs from immunotherapy are related to the immunotherapy. So the all-cause incidence of AKI in cancer is anywhere from 15 to 25%, whereas in the study by Sitapathy et al., it shows that the incidence of immune checkpoint inhibitor-associated AKI is anywhere from 2 to 5%. Now, in terms of the incidence, typically PD-L1 inhibitors and PD-1 inhibitors are less than 2%, whereas CTLA-4 and combined immune checkpoint inhibitors are closer to the 5% mark. In terms of times of onset, it typically occurs between 12 to 16 weeks. However, approximately 10% of cases in the Sitapathy study found that cases were seen approximately 1 year after initiation of the immune checkpoint inhibitor and even 6 months after discontinuation of the immune checkpoint inhibitor. Now, in terms of risk factors, low EGFR has been shown to be a risk factor in nephrotoxic drugs, particularly proton pump inhibitors, in addition to combination immunotherapy, and also the presence of other immune-related adverse events, for instance, concomitant rash or concomitant colitis. In terms of histopathologic features, approximately 80 to 90% of these cases are associated with interstitial nephritis. These cases can also be rarely associated with ATN, and increasingly they're found to be associated with glomerulopathies. In terms of diagnosis of these cases, it's a very challenging diagnosis due to the absence of reliable clinical or laboratory features. The urinary findings are highly variable. Approximately 17% of patients in the study by Gupta et al. Had eosinophilia. 40% had some blood in the urine, 41% had positive leukocyte esterase, and 62% had some degree of proteinuria. So again, to highlight that these urinary findings are neither sensitive or specific. Urinary biomarkers are being investigated as a diagnostic tool. Urinary CXCL9 is currently used in research labs, and it has shown promise. Primarily, other sites are using a CRP and a urine retinol binding to creatinine ratio, although that's only at one single site at the Mayo Clinic. And then other sites are using blood biomarkers, such as our site, which uses a CRP and a soluble interleukin-2 receptor. There have been studies, such as a case series of 11 patients, which suggested the use of PET CT scan in terms of diagnosing immune checkpoint inhibitor AKI, but the gold standard remains renal biopsy. Now, in terms of the management of immune checkpoint-associated AKI, the first thing to do is to hold the immune checkpoint inhibitor and discontinue any AIN-associated medications, primarily PPIs. The next step is to start steroids. With less severe cases of AKI, I recommend 1 milligram per kilogram. And with more severe cases of AKI, usually I start with a couple of days of IV steroids. The duration of steroid treatment is typically about 6 to 8 weeks. However, a study by Megan Seiss has shown that a shorter steroid course, 3 to 4 weeks, has been shown to be just as efficacious. One thing to keep in mind with prolonged steroid use is that these patients need to be on PCP prophylaxis and also GI prophylaxis. And then finally, in the treatment of these patients, there are patients that tend to be steroid refractory or patients that cannot receive steroids, whether it be due to uncontrolled diabetes or psychiatric conditions. In those patients, tocilizumab and mycophenolate have been trialed. Anecdotally, I've had limited success with those medications. And one medication, a TNF-alpha inhibitor, infliximab, has had growing popularity and increasing data behind it. In fact, some centers are using it as first-line therapy. Now, the next question is, if a patient develops an immune checkpoint inhibitor-associated AKI, can we rechallenge them safely? Historically, the oncologic data has shied against rechallenge, although that is changing with some of the nephrology data. So the nephrology data suggests that about 16 to 25% of patients that are rechallenged with immune checkpoint inhibitors have a risk of recurrent ICI-AKI. So generally, expert opinion recommends that patients that develop ICI-AKI can be safely rechallenged. These patients are often rechallenged with low-dose steroids for the first 2 cycles, although that is something to discuss with the oncologists because many oncologists feel that steroids can affect cancer response, and so that would be an open discussion with them. Now, moving on to our targeted therapies. We'll start off by talking about VEGF inhibitors. So there are 2 types of VEGF inhibition. There's direct VEGF inhibition with medications like bevacizumab, and so those have been associated with thrombotic microangiopathy, whereas indirect VEGF or tyrosine kinase inhibitors, which work downstream like axitinib, have been more associated with podocytopathies. Now, these medications can cross over, so these indirect VEGF inhibitors and tyrosine kinase inhibitors can cause thrombotic microangiopathies and vice versa. Now, in terms of renal manifestations, commonly hypertension is a frequent symptom. and certain medications have higher incidences of hypertension compared to others. And then proteinuria, again, is quite common. Renal limited thrombotic microangiopathy. And keep in mind that these patients will oftentimes develop thromboembolic events, including renal vein thrombosis. Now, in terms of the mechanism of injury in these patients, typically it's related to inhibition of VEGF. So you have vasoconstriction, endothelial rarefication, podocyte damage because you need VEGF for healthy podocyte function, pressure natriuresis from hypertension, and decreased lymphangiogenesis from decreased VEGF. Typically, treatment involves holding the medication. Typically, a threshold that many people use is a urine protein greater than 2 grams over 24 hours. One thing I would like to highlight, though, it does really depend on the clinical scenario. Is the VEGF inhibitor one of the patient's last lines of therapy, in which case perhaps a discussion with the patient and with the oncologist would be whether it would be reasonable to continue monitoring with high levels of protein. And also supportive care is quite important. So blood pressure control, so medications that enhance vasodilation, primarily dihydropyridine calcium channel blockers, medications that reduce proteinuria, so ACEs and ARBs, and potentially long-acting nitrates, which can act as nitric oxide donors. Now, in terms of other proposed therapies, anti-complement therapy potentially is an option, especially if the patient has evidence of complement dysfunction, for instance, such as an elevated soluble C5b9 level. In terms of rechallenge, we have published data at our center suggesting that in patients that need to be on VEGF therapy, that have had disease progression, potentially using prophylactic anti-complement therapy may be a reasonable option to consider. Now, moving on to our next case, case 4. We have an 84-year-old male with combined non-small cell lung cancer, adenocarcinoma, and small cell lung cancer with a MET exon 14 skipping mutation that had disease progression after 4 cycles of carboplatin etoposide. He was started on capmatinib, and 1 week after initiation, his serum creatinine increased from a baseline of 1.3 to 1.6 to 2.44 milligrams per deciliter. He has no dizziness, nausea, emesis, or pain. His past medical history is listed in addition to his medications. His labs are largely normal, with the exception of the creatinine elevation with a bland urinalysis and a normal urine protein to creatinine ratio, and no hydronephrosis on renal ultrasound. All right. So his treatment course is graphically represented over here, and this is actually a real case that was published. So 1 week after initiation of the capmatinib, his serum creatinine increased from 1.6 to 2.44. The capmatinib was held for approximately 3 days, and his serum creatinine subsequently improved from 2.44 to 1.84 milligrams per deciliter. The capmatinib was restarted, and approximately 2 weeks later, his serum creatinine again increased from 1.84 to 2.22 milligrams per deciliter. And then the capmatinib was withheld for approximately 5 days, and his serum creatinine decreased again. Now, during this time, he also had a cystatin C related creatinine, which is shown over here. And as you can see, his cystatin C creatinine remained relatively stable throughout his treatment course. And then over here, he had a renal iothalamate level clearance as well performed, which correlated with his cystatin C eGFR. So talking about MET inhibitors, they're primarily used in non-small cell lung cancer. And so their renal manifestation is primarily pseudo-acute kidney injury. The reason for that is MET inhibition of the MATE1, 2, and or the OCT transporters, which results in the pseudo-AKI. Now, in terms of management, typically these patients just simply need to be monitored with alternate measures of eGFR, so cystatin C, or alternatively a measured GFR measurement like iohexol or iothalamate. Now, I've listed in this chart several medications that can be associated with pseudo-AKI. So these ALK inhibitors are primarily used in non-small cell lung cancer. And so they similarly inhibit MATE1 and OCT and frequently cause acute kidney injury. Although in very, very rare cases, they have been shown to cause acute tubular injury, but the vast majority of them are pseudo-AKI. Similarly, the CDK4/6 inhibitors can also cause pseudo-AKI, and similarly, rare cases of acute tubular injury, which makes cases with ALK inhibitors and CDK4/6 inhibitors sometimes difficult to manage. And finally, the PARP inhibitors and the MET tyrosine kinase inhibitors are also associated with pseudo-AKI. All right. Now, moving on to case 5, we have a 65-year-old business executive who presents with a 3-week history of fatigue and back pain. His vitals are 125/75 with a heart rate of 95 and a temperature of 99 on room air. His labs are notable for an elevated serum calcium of 14 milligrams per deciliter and an elevated creatinine of 2.9 milligrams per deciliter from a baseline of 1.7. He is anemic on labs. He has an M spike on his serum protein electrophoresis. And in terms of his free light chains, he has a lambda predominance, 3,000 compared to 30 kappa milligrams per liter with a ratio of 100. His urinalysis is planned with primarily tubular proteinuria, 8 grams, and an albumin to creatinine ratio of only 500 milligrams. So the patient does meet the criteria for multiple myeloma, which is clonal proliferation of greater than 10%, or biopsy-proven extramedullary plasmacytoma, and greater than 1 CRAB feature, CRAB standing for hypercalcemia, renal insufficiency, anemia, or bone lesions. The other criteria is greater than 1 SLIM, so it's a plasma cell greater than 60%, a light chain ratio greater than 100, or an MRI with a lytic lesion, or a myeloma-defining event. The question here is, which of the following can precipitate cast formation? Is it number 1, ACEs or ARBs, number 2, diuretics, number 3, NSAID use, or number 4, all of the above? All right. I think we'll move on and talk about AKI with multiple myeloma. So multiple myeloma is the second most common hematologic malignancy, with renal impairment being common in multiple myeloma. Approximately 50% of patients with multiple myeloma will develop some degree of renal impairment, whether that's acute kidney injury or some degree of chronic kidney disease. With newly diagnosed multiple myeloma, approximately 16 to 31% of patients will have an acute kidney injury. In terms of the implications of renal impairment, of all the multiple myeloma defining events, AKI has the highest impact on survival. So renal impairment in multiple myeloma results in higher earlier mortality, worse survival, and limited access to novel treatments. In terms of risk factors with CAS nephropathy, the degree of serum free light chain elevation is crucial. It's typically very rare, less than 50 milligrams per deciliter. And then, like our case in the prior slide, ACEs, ARBs, diuretics, NSAIDs, contrast, anything that affects intrarenal hemodynamics can certainly precipitate CAS formation. And so here we'll talk a little bit about the pathogenesis of CAS nephropathy and multiple myeloma. So multiple myeloma makes excess free light chains that are normally filtered in the glomerulus, and they're uptaken by the proximal convoluted tubule. So the excess free light chains from the multiple myeloma overwhelm the proximal convoluted tubular's capacity. So within the proximal convoluted tubule, you have endocytosis, lysosomal degradation, and later upregulation of pro-inflammatory and apoptotic processes resulting in proximal convoluted tubular damage. Additionally, the free light chains make it to the distal convoluted tubule where they combine with TAM horsefall protein and form casts. Now, in terms of the renal impact of multiple myeloma, like previously mentioned, there's decreased overall survival and decreased response rates. Patients with multiple myeloma requiring renal replacement therapy have a median overall survival much less than patients that never require renal replacement therapy. And one critical point that I'd like to make is patients with renal recovery have the same prognosis as patients that have never developed an AKI. So it's really important to aggressively treat these patients and do our best to salvage as much renal function as we can. Now, the critical point is that free light chains are toxic, and we need to reduce both the free light chain burden and suppress further light chain formation, while also addressing any precipitating factors. This is done through volume expansion if the patients can tolerate it. For instance, if the patient is hypercalcemic or hasn't been eating or drinking very much due to pain or was on diuretics. The second critical thing is multiple myeloma treatment. Typically, this is with a combination of daratumumab, Cytoxan, bortezomib, and dexamethasone currently. And finally, and an area of controversy is the use of extracorporeal management to reduce free light chains. So I'll first talk about this slide. So to set the stage, a study by Nelson Learn at the Mayo Clinic in 2008 showed that a rapid reduction in free light chains is predictive of recovery from AKI, although we should note that there's no control group in that study. At the same time, there have been approximately 6 major trials that have looked at extracorporeal removal of free light chains, and the results have been relatively mixed and mostly negative. So I've highlighted on the right the Clark trial, which is the largest PLEX trial, published in 2005, which showed that there was no improvement in renal function with PLEX. There were 2 criticisms of this Clark trial, which were that there was a lack of biopsy-confirmed light chain cast nephropathy, and the use of a composite outcome of death, dialysis outcome, and eGFR less than 30. Now, going back to our previous slide. So this study was the MUIR trial. So the MUIR trial used high cutoff dialyzers. And so high cutoff dialyzers are a little bit different in that they have a larger pore size. And the MUIR study by Dr. Brudu found that patients that received high cutoff hemodialysis did not meet their primary endpoint, which is renal recovery at 3 months, but they did meet a secondary endpoint of renal recovery at 6 months. So this study has shown promise. Although at the same time, like I said, we have many studies that have conflicting data. There was a study published 2 years later, the ULIGHT study by Dr. Hutchinson, which found that it was a negative trial, and these patients had no improvement in renal recovery rates, and in fact had higher mortality and higher infection rates. So to summarize, currently the expert opinion suggests that if you have an involved free light chain greater than 150 milligrams per deciliter with Bence-Jones proteinuria, preferably with a urine M spike greater than 200 milligrams per deciliter and albuminuria less than 10%, that a strong consideration for starting multiple myeloma treatment with a combination of DARA, bortezomib, Cytoxan, and dexamethasone with daily PLEX therapy, with the goal to reduce free light chains by 50% by the end of cycle 1. Although it is very important to highlight that this expert recommendation may change because the myeloma landscape is evolving quite rapidly with the newer medications like daratumumab, CAR T-cell therapy, and bispecific therapy resulting in very rapid decreases in free light chains, sometimes greater than the rate of plasmapheresis. So in terms of my approach, the first question I ask is whether or not this is the first episode or whether this is a relapse. Secondly, is this a correct diagnosis of light chain cast nephropathy? Do they meet all of the suggested expert criteria? What is the rate of rise for the light chain and the creatinine? For instance, if the patient developed light chain cast nephropathy 3 weeks ago and has a severe AKI, at that point, perhaps PLEX would be less relevant. And does the patient have a biopsy diagnosis? And then again, in terms of the proposed light chain cast nephropathy criteria, it's an involved free light chain greater than 150 milligrams per deciliter, urine albuminuria less than 10%, and a urine M spike greater than 200 milligrams per deciliter. Now, keep in mind the risks associated with PLEX. These include DIC, infections, electrolytes, electrolyte abnormalities. And then a critical thing is there should be close collaboration with the multiple myeloma team and a discussion of what the next line of treatment is and how soon the patient is going to get their myeloma treatment. For instance, if there's a delay in the patient getting their myeloma treatment while they're waiting for insurance approval, then perhaps it makes sense to start PLEX early. But if the patient is going to get inpatient daratumumab, perhaps it makes sense that in that patient population that you can potentially defer PLEX. So I'd like to finish off with a few take-home messages. Acute kidney injury is a common complication in cancer and can be the result of patient-specific or cancer-specific factors. It can be a result of treatment-related factors, such as the type of chemotherapy, or both. Again, AKI has significant implications on the cancer treatment, whether it's the dosing of the cancer therapeutic agent, the therapeutic options, cancer prognosis, and mortality. And then finally, in terms of working up a patient with AKI and cancer, consider the type of antineoplastic agent, whether it's conventional chemotherapy, immunotherapy, adoptive cell therapy, targeted therapies, and the mechanism of cancer treatments when formulating a differential. All right, with that, I will end my talk.